Hello, this is Nicole Freeland, and today we will be discussing Chapter 38, which is Care of Women with Reproductive Disorders. Your objectives for this section will be, the student will be able to examine normal physiology considering age-related changes to the female reproductive system. The student should be able to discuss common menstrual disorders and nursing interventions for each. You should be able to compare methods of contraception. You should be able to examine causes and treatment of infertility. You should be able to present changes associated with menopause, treatment options, and nursing interventions. You should also be able to explain the screening procedures recommended for maintaining reproductive health. And you should be able to distinguish the nurse's role during screening procedures, data collection, and education of women concerning reproductive health. Women's healthcare has made vast improvement over the last 120 years. It focuses on the physical, psychological, and spiritual well-being of women. Women do have unique healthcare needs as our body composition, hormones, and reproductive organs differ from those of men. The Women's Health Equity Act passed in 1990 contains laws that increase women's access to health services. Adult women do require information on pap smears, breast self-examination, nutrition, exercise, and lifestyle management. As the nurse, we must provide support, reassurance, understanding of cultural and personal needs, and education to our female patients. Sexual maturation begins with puberty. This is the period of sexual maturation. Onset is usually anywhere from 9 years of age to 17 years of age, with the average onset being around 12 years of age. During this time, accelerated growth is seen, the hips of the female widen, breast tissue develops, and axillary and pubic hair appear. The onset of menstruation completes puberty. This is known as menarche. Menstruation, as stated before, the beginning of menstruation is known as menarche. Menstruation is the shedding of the uterine lining, occurring approximately every 4 weeks throughout childbearing years, except during pregnancy. During the first year following menarche, the menstrual cycle may be somewhat irregular, but by the second year, a regular cycle of 28 days is usually established. Menstrual bleeding usually occurs approximately 14 days after ovulation and lasts anywhere from 2 to 8 days. Blood loss on average is between 40 to 80 milliliters. The length of the cycle can be influenced by stress, drugs, nutrition, and illness. Mild cramping and mood swings may occur due to hormonal changes during this time. Hormonal changes may also contribute to breast tenderness during the midpoint of menstruation. Mittelschmerz is sharp lower abdominal pain that is experienced around the time of ovulation for some females. This will be in the lower portion of either the right or left quadrant, depending on which ovary is releasing ovum at that time. Once a menstrual pattern is established, a deviation in this pattern is reason to consult a healthcare provider. The ovarian cycle has 2 phases. The first phase is the follicular phase. It makes up the first 14 days of a 28-day cycle. Follicle stimulating hormone, or FSH, and luteinizing hormone, LH, stimulate ova maturation for fertilization. The ovum is released, known as ovulation, around day 14 and estrogen is at its peak during this time. Phase 2 is known as the luteal phase. This occurs on days 15 to 28. Luteinizing hormone and progesterone are at their peak during this time. The lining of the uterus increases during this time in preparation for fertilization. If fertilization does not occur, menstruation begins and the cycle repeats itself. The menstrual cycle itself consists of 4 stages. Stage 1 is known as the dismantling stage. This is when the endometrium sloughs away from the inner uterine wall and menstrual flow begins. Progesterone and estrogen are no longer secreted, and new follicles start to mature. The second stage is known as the estrogen or proliferative stage. This is when follicle growth occurs and eggs mature. The endometrium returns to its normal state and then begins to thicken in response to estrogen. Stage 3 is the ovulation stage. We just discussed this in the previous slide. And then stage 4 is post-ovulatory or the progesterone stage. This is when the corpus luteum secretes progesterone. Endometrium continues to thicken in response to estrogen and progesterone, and the uterus prepares to receive a fertilized ovum. So we will discuss normal vaginal discharge. The vagina itself is a warm, moist, dark vault that is a great environment for bacterial growth. Normal vaginal secretions include cervical mucus, endometrial fluid, exudate from Bartholin gland and the Skene ducts, and normal flora found within the vagina. Vaginal discharge is usually off-white in color and odorless. This is controlled by lactic acid that is found within our vagina. The lactic acid controls the pH of our vagina, which is normally acidic in nature. This helps to protect against infections. If our lactic acid is out of balance, our pH will be off balance and the risk for infection increases. Secretions increase during pregnancy and mid-menstrual cycle, and secretions normally decrease after menopause. Normal breast tissue is composed of adipose tissue, lobules, ducts, and fibrous tissues. Asymmetry in one breast to the other is very common. Breast tenderness is common mid-menstrual cycle, as I stressed before in the earlier slide. Age, pregnancy, medications, and diet can all affect breast density. Now we'll discuss some menstrual dysfunctions. The first one we will discuss is premenstrual syndrome, commonly known as PMS. This occurs during the luteal phase of the ovarian cycle. Signs and symptoms occur between ovulation and menstruation and include abdominal bloating, breast tenderness, irritability, appetite changes, fatigue, and mood swings. Premenstrual dysphoric disorder is a more serious disorder. It is thought to be the result of abnormal serotonin responses to normal changes in estrogen levels during the menstrual cycle. Symptoms occur between ovulation and menstruation and do not continue after menstruation. These include depressed mood, anxiety, irritability, difficulty concentrating, change in appetite and sleep patterns, breast tenderness, bloating, weight gain, and headaches. Strategies used for self-care for PMDD include stress management exercises, lifestyle changes, and maintaining a healthy diet especially a diet rich in complex carbohydrates and fiber, such as whole grains, in your breads, pastas, and lentils. It is recommended that alcohol, red meat, sugar, all be avoided, as it's thought that these exacerbate the symptoms of PMDD. Then there is dysmenorrhea. Dysmenorrhea is painful menstruation, which is a very common complaint for females. There are two classifications of dysmenorrhea. The first is primary, the second being secondary. Primary dysmenorrhea usually begins 6 to 12 months after menarche and is thought to be the cause of high levels of prostaglandins, causing uterine contractions comparable to those experienced in the second stage of labor. Other symptoms include backache, weakness, decreased appetite, dizziness, headache, and poor concentration may also occur. Treatment for these individuals include heating pads. This causes vasodilation, which can actually decrease abdominal cramping, back massage, effleurage, which is abdominal massage, and exercise that releases endorphins, in turn suppressing prostaglandins. NSAIDs may also be recommended, as these are prostaglandin inhibitors. Oral contraceptives may also be prescribed to aid in relief of symptoms. Two very common oral contraceptives. The first one is Seasonal. This provides longer periods of pain-free amenorrhea or without menstruation. It only provides 4 menstrual cycles during a year. And then Librel is another oral contraceptive that may be used. It prevents menstruation for 1 year total. Then we have secondary dysmenorrhea. Secondary dysmenorrhea, it generally occurs in older females or after the age of 25. It's thought to be caused by pelvic pathology, such as that seen in endometriosis, pelvic inflammatory disease, uterine polyps, and fibroids. The pain itself is associated with the secondary dysmenorrhea. It's characterized by dull lower abdominal pain that radiates to the back or thighs. The pain might occur before menstrual period and last throughout the days of menstrual flow. Management for secondary dysmenorrhea includes treating the cause of the pelvic pathology, and temporary relief may be obtained with the same therapies used for primary dysmenorrhea. Contraception is essential for preventing unwanted, unintended pregnancies. Considerations should include the patient's maturity, their age, their lifestyle. When it comes to choosing different contraceptive options, we need to be aware of those that are at an increased risk for STIs, STDs. These individuals will need to also use a barrier method or condom, actually, or abstinence, as well as oral contraceptives and other forms of contraception so that we decrease the risk of STIs, STDs. The different contraceptive options are discussed on pages 889 through 892 on table 38-8. Please be familiar with the different contraceptive options, know how they work, their side effects, and the effectiveness of the different options. Another option is natural family planning. This is known as fertility awareness. It does involve identifying signs of ovulation and abstaining from intercourse during periods of fertility. The body temperature, or the basal body temperature, is monitored each morning, and when there is a rise that occurs, ovulation is beginning. This is when you need to abstain from intercourse. There's also a cervical mucus test called the Billings method that can be used to track the occurrence of ovulation. The calendar or rhythm method is based on the knowledge that ovulation occurs 14 days before menstruation, and therefore keeping track of the individual's menstrual cycle. This can help predict the time of ovulation. Emergency contraception. This is known as the morning after pill. This is used after unprotected intercourse that was not planned. This is not meant to be used on a regular basis. It was developed to decrease the number of unwanted pregnancies and elective abortions. Emergency contraception prevents pregnancy by preventing ovulation or fertilization, or by slowing transport of the sperm and egg, or altering the uterine lining to prevent implantation. This emergency contraception is known as Plan B. Infertility is the difficulty conceiving after having tried for at least 1 year. It's thought at this time that the woman and her partner are evaluated so that they may make an informed, individualized decision concerning conception, especially if they want to seek fertility assistance. Also, screening for genetic disorders may be required at that time. There are two types of infertility. The first is primary, and the second being secondary infertility. Primary infertility is the inability of a couple to conceive a child after at least 1 year of active, unprotected sexual relations without the use of contraceptives. Secondary infertility is the inability to conceive after having once conceived and maintained a pregnancy long enough to deliver a viable infant. Causes of infertility include problems with ovulation, an abnormality in the pathway between the cervix and fallopian tubes, an abnormality in the endometrium of the uterus, or a malformation of the uterus, tumors in the reproductive tract, vaginal or cervical environment that is inhospitable to sperm motility or viability, or both. This does have quite an emotional impact on women and their partners, so they may require support during this time, especially support from a psychologist, someone specialized in treating anxiety and depression. Nursing management includes discussing with the patients regarding the infertility, and may include non-medical actions such as the use of water-soluble lubricants, having the male partner avoid environments that cause high scrotal temperatures, using condoms when the woman has an elevated anti-sperm antibody level, and stress management, nutrition counseling, and lifestyle analysis. ART, or assisted reproduction therapies, are available, but are associated with many ethical and legal issues these days, such as the risk of having a multi-fetal pregnancy, freezing embryos for later use, and the use of a surrogate mother. Examples of ART procedures include in vitro fertilization, This is when a woman's eggs are collected from the ovary, fertilized in a laboratory, and then transferred into the uterus at the embryo stage of development. There's also zygote intrafallopian transfer. So after in vitro fertilization, the ovum is placed into the fallopian tube at the zygote stage of development. Another procedure is therapeutic donor insemination. This is when a donor sperm inseminates the female. There's also intracytoplasmic sperm injection. This is the injection of one live sperm directly into the mature egg. And then there is also the use of a surrogate mother. Menopause is the cessation of menses for 12 consecutive months. The perimenopausal or climacteric period is a time around the actual cessation of the menstrual cycle. Signs and symptoms include hot flashes, night sweats, low estrogen levels, and these symptoms usually decrease as the woman's body adjusts to the lower levels of estrogen. The aging process and the decrease in estrogen levels can cause thinning of the vaginal wall, resulting in atrophy, as well as dryness and itching of the vagina, known as pruritus. These changes may result in painful sexual relationships, known as dyspareunia, and can also lead to increased susceptibility of infections because the vaginal pH increases. Some older adult care points to keep in mind. The significant reduction of estrogen after menopause decreases by about 80% and decreases natural vaginal lubrication. Women may be prescribed vaginal creams containing estrogen to restore moisture and elasticity to vaginal tissues. Estrogen cream used as a lubricant for sexual intercourse is discouraged because the cream may damage latex condoms and other methods of birth control. Should be used until full menopause occurs to avoid pregnancy. So some health risks that are associated with menopause. First off, I don't have this listed, but the decrease in estrogen levels causes the vaginal walls to atrophy. There's also increased vaginal dryness because of decreased vaginal lubrication after menopause, which can increase the risk for injury during intercourse. And then we have osteoporosis. Osteoporosis is a decrease in bone mass that increases the risk for bone fractures. Because of the decrease in estrogen that occurs after menopause, this slows bone growth and the bone starts to deteriorate and it thins, which can lead to more fractures after menopause. Something else that contributes to osteoporosis are smoking habits, excessive alcohol intake, and excessive caffeine intake. So it's important to educate our patients over the cessation of smoking and drinking and possibly giving up their caffeine after menopause. Coronary heart disease is also an increased risk for women after menopause. Postmenopausal women are at an increase because of changes in lipid metabolism and a rise in total cholesterol. Diet and exercise can help minimize the effects of these risks. Treatment options include hormone therapy replacement, or HRT. This was once the main intervention for postmenopausal women, but research has offered new evidence that HRT can increase the risk of developing blood clots, stroke, heart attack, and even breast cancers. Bioidentical hormones are hormones such as estradiol, transdermal patches, or oral micronized progesterone. They have chemical structures identical to hormones produced in the human body but are clinically synthesized. These may help decrease some of the side effects after menopause. Alternative therapies include CAM therapies that might be helpful in relieving specific discomforts of menopause. Homeopathy, acupuncture, and certain herbs may offer relief. Each may have contraindications as well. Phytoestrogens, soy products, and vitamins B, C, and E have also been helpful in relieving menopausal discomforts. Health screenings and assessments. Primary prevention is designed to decrease the probability of becoming ill, maintaining health and nutrition, and providing immunizations. Secondary prevention is designed to focus on detection of specific diseases a patient is at risk for, so that early treatment may begin if necessary. Tertiary prevention minimizes the impact of an already diagnosed condition. As the nurse, it is our responsibility to introduce ourselves, ask pertinent questions, and document all information gathered. It is our responsibility to collect the data during a health screening and assessment. Breast self-examinations are a great screening tool for early detection of possible breast cancerous tissue. This should be performed monthly, 1 week after menstruation begins, or on a specific date each month if you are postmenopausal. Other screening tests for breast cancer include mammograms, tomosynthesis, which is a 3-dimensional mammography, testing for the BRCA1 and BRCA2 gene mutations, and then there is research currently on thermography to test for cancerous tissues as well. Another important form of self-examination is vulvar self-examination. We need to educate our patients over the importance of this self-examination because the earlier that cervical and other forms of female cancers are detected, the greater the likelihood of survival for these patients. We need to educate them on how to perform this examination. It is usually done in the sitting position. One hand is used to part the labia majora, and then the tissue itself is inspected from the mons pubis all the way to the anus, and the patient observes the tissue appearance. You would observe for any abnormal lesions, any abnormal bumps, any abnormal discolorations, and report any abnormal findings to their healthcare provider. There are many different kinds of diagnostic tests involved in women's health. It is important as a nurse that we educate the patient over the procedure, and then we assist with the test itself if necessary. Many procedures do require informed consent before the procedure. So make sure that you do, in fact, gain informed consent from the patient themselves before any form of anesthetic or mentally altering medication is given, including pain medications. We need to answer all of the patient's questions clearly and accurately. If you do not know the answer to the question, that's okay. Please do not give them a false response. Please just know where to find the answer to the question if necessary. The different diagnostic tests that are used for women's health are listed on table 38-3. That is on pages 898 to 899. I would like for you all to study this table, know these diagnostic tests, their purpose, the description, and the nursing implications that you need to know for these diagnostic tests. Another diagnostic test, a major diagnostic test that is done for women's health is the pelvic exam. It's our responsibility as the nurse to assemble the equipment, and then we direct the patient to the procedure and what to expect. We would assist the patient with lying down, assuming the correct position, relaxing their legs, and helping them with breathing exercises throughout the procedure to help them relax and stay calm and keep the muscles from tensing up. Disposable tissues may need to be provided after the pelvic exam to get rid of the excess lubrication. And then teaching may include the purpose of the test performed and the need for routine checkups. A Pap test is now recommended every 3 years from ages 21 to 29. If HPV is present, HPV is human papillomavirus. Testing every 5 years thereafter until the age of 65 is necessary. Nursing management for women's reproductive care includes collecting a thorough gynecological history. We need to collect data regarding the patient's reproductive history and their gynecological concerns. We will do this by providing a trusting and supportive environment for the patient. Review of sexual health information should include the 5 Ps. The 5 Ps are partners, practices, protection from STIs, past history of STIs, and prevention of pregnancy. A focused assessment will include gathering data about the age that menstruation began for the patient, how regular their periods are, how often they occur, how long they last, how heavy or light is their flow, do they ever pass clots or pieces of tissue during menstruation, do they experience pain before, during, or after their period, do they experience any cramps, headaches, abdominal, or back pain at other times of the month, does your patient experience mood swings, depression, periods of tearfulness associated with their menstrual cycle? Do they have any abnormal vaginal discharge or itching? Do they ever have any bleeding or spotting between their periods? Do they have problems with urination, including burning, pain, or incontinence? How many times has the patient been pregnant? Have they had any miscarriages? Have they ever had any pelvic infections? Do they in fact perform self-examinations such as breast and vulvar examinations? When was their last Pap smear? Have they had a mammogram? If so, when was their last mammogram? Do they take any routine medications? What methods, if any, of birth control do they use? Do they feel comfortable with their method of birth control, or do they desire to change it? And do they have any specific concerns or questions that have not been addressed? Some cultural considerations when it comes to performing a thorough history and physical include significance in the area of women's health care, cultural views regarding sexuality, reproduction, and the role of women in society, have a direct bearing on the type of care sought and the amount and type of information the woman is willing and able to provide. The nurse must not pass judgment based on her own cultural bias, but must be culturally sensitive and supportive to the needs of women from diverse cultural backgrounds. Nursing care of patients with gynecologic problems is very specific to the disorder they are experiencing. However, prevention of infection, effective patient education, and emotional support are all something that we can provide to our patients as well. Their plan of care must address education, pain management needs, emotional and physical care, family impact, cultural influences, and financial constraints of the patient themselves. The first disorder of the female reproductive tract that we will discuss is pelvic relaxation syndrome. This includes cystocele, rectocele, enterocele, and uterine prolapse. When the muscles, ligaments, and fascia that support the pelvic floor weaken, the pelvic organs may descend toward the vaginal vault. This can affect the bladder, known as cystocele, the rectum, known as rectocele, the bowel, known as enterocele, and the uterus, known as uterine prolapse. Pathophysiology, this includes because the lack of estrogen results in weakening of tissue structures. Pelvic relaxation syndrome is more likely to occur as a woman ages. The bladder protrudes through the vaginal wall, forming a cystocele, or into the rectum, forming a rectocele. As expected, lifespan increases. These problems have increased in frequency. Heavy lifting, constipation, obesity all contribute to the weakening of the pelvic floor muscles and tissue. Pelvic surgery and the strain of vaginal childbirth may also contribute to the development of pelvic relaxation syndrome. Signs and symptoms include complaints of general symptoms that include a sense of fullness in the pelvis and a backache. Stress incontinence, which is loss of small amount of urine during coughing, sneezing, or lifting objects, may also occur. Diagnosis is confirmed by history and physical examination. We will obtain an obstetric history concerning the number of vaginal deliveries and the size of the infants delivered. A history of stress incontinence or constipation may indicate how the problem may interfere with activities of daily living. A CT scan may be required if other pelvic pathology is suspected. The patient, the healthcare provider, all determine whether a non-surgical or a surgical approach to management is most appropriate. Treatment includes non-surgical management will include Kegel exercises to strengthen the pelvic floor muscles. Lifestyle changes that include increasing fluid intake and a high fiber diet to prevent constipation, avoiding heavy lifting, and maintaining an optimal weight for these patients. Hormone therapy may be prescribed. Episiotomy, which is a hard rubber or plastic ring, can be fitted into the vagina by the healthcare provider to provide support to the pelvic structures themselves. Surgical management includes repair of a cystocele or a rectocele, called an anterior-posterior repair. A hysterectomy, which is the removal of the uterus, may also be indicated. Management of pelvic prolapse includes minimally invasive surgery. Surgical repair may be accomplished laparoscopically, abdominally, or transvaginally. The second disorder of the female reproductive tract that we will discuss is polycystic ovarian syndrome, or PCOS. This is a congenital condition in which many cysts develop on one or both of the ovaries. It produces excess estrogen levels, high levels of testosterone and LH, and low levels of FSH. Signs and symptoms include irregular menstruation, infertility, hyperinsulinemia or high blood sugar, and glucose tolerance problems. Excessive hair on the body, known as hirsutism, may also be a common symptom. Treatment involves use of oral contraceptives to inhibit LH and testosterone production. Surgical removal of the cyst may also be indicated. If pregnancy is desired by the patient, ovulation-stimulating medications are prescribed, and we need to advise the patient concerning the importance of follow-up care to monitor the progress of this condition. Dysfunctional uterine bleeding is bleeding that occurs at times other than the normal menstrual cycle or abnormal bleeding during menstruation. Uterine bleeding may be considered abnormal if the interval between menstruation is less than 21 days or more than 45 days, the duration of menstrual flow is more than 7 days, or the amount of blood loss exceeds 80 milliliters. Oligomenorrhea is decreased menstruation. This usually refers to menstrual periods that occur at an interval of 45 days or longer. The cause is often the thyroid, the hypothalamus, or ovarian function. Hormone therapy is the treatment of choice, and the woman should be educated concerning advantages and disadvantages of hormone therapy. The use of oral contraceptives can decrease menstrual flow. Structural abnormalities can cause obstructions or destruction of the endometrium, resulting in oligomenorrhea. Amenorrhea is absent menstruation. There is primary and secondary amenorrhea. Primary refers to women who have not had a normal onset of menstrual periods. Secondary applies to women who began normal menses that later ceased. Some causes include anatomic defects, such as an imperforate hymen, endocrine dysfunction, female hormones, chronic diseases, extreme weight loss or obesity, emotional disturbances, drug side effects, excessive exercise, and poor nutrition. Amenorrhea is a normal occurrence during pregnancy. Goals and treatment include progression of normal pubertal development, prevention of complications such as osteoporosis, endometrial hyperplasia or heart disease, and promotion of fertility. Metrorrhagia is bleeding between menstrual periods. Occasionally, a brief episode of spotting occurs 14 days before the expected menstrual period. This corresponds with ovulation and is known as middle, MITTLE, staining. This is considered to be normal. Women who take oral contraceptives or have an IUD may also experience breakthrough bleeding. This usually resolves after adjustment of the medication or dosage. Menorrhagia is excessive menstrual bleeding or duration of the menstrual period. There are many causes, including hormone imbalances, malignancies, fibroids, infections, and the use of some certain drugs. Symptoms include frequent nosebleeds and delayed postpartum hemorrhage. Blood tests should be taken during menstruation for accurate diagnosis. Treatment of menorrhagia depends on the cause. Hemoglobin and hematocrit should always be assessed to determine the seriousness of the blood loss. And non-hormonal treatment of menorrhagia can be treated with tranexamic acid. This oral medication works by reducing clot breakdown in the uterus. Abnormal uterine bleeding is uterine bleeding not related to the menstrual period itself. Causes often include anovulation and a failure of hormonal changes during the menstrual cycle. It most often occurs at the beginning or end of the reproductive years. Bleeding from continuous estrogen production can also occur as a result of thyroid dysfunction, polycystic ovarian disease, infection, trauma, or neoplasms. Use of some herbal medications that promote estrogen activity can also cause dysfunctional or abnormal uterine bleeding. We need to monitor the hemoglobin and hematocrit, as well as hospitalization may be required if the hemoglobin falls below 8. Severe bleeding may be treated with intravenous conjugated estrogens, known as Premarin, until bleeding stops or slows significantly. A dilation and evacuation, formerly known as a dilatation and curettage, and endometrial biopsy may be required as well. Persistent anovulation with continuous estrogen stimulation of the endometrium can cause abnormal tissue changes in the uterus. Nursing interventions include educating the patient concerning the use of unsupervised CAM therapies and proper use of oral contraceptives, providing support during treatments, and ensuring that the patient is aware of treatment options. Leiomyomas are uterine fibroids. They are benign tumors of the uterine muscle. Their growth is influenced by ovarian hormones, and they are common in women taking birth control pills. They spontaneously shrink during and after menopause. Common symptoms include backache, a sense of lower abdominal pressure, constipation, urinary frequency or incontinence, and abnormal uterine bleeding. A pelvic examination and ultrasound may help to confirm this diagnosis. Medical management depends on the size and location of the fibroids, the symptoms experienced, the desire for future pregnancies, and how near the woman is to natural menopause. In mild cases, monitoring and supportive care to relieve symptoms are indicated. NSAIDs or oral contraceptives may be prescribed as well to help relieve pain. Oral contraceptives are used to help prevent and decrease pain during menstruation. In severe cases, Lupron or Synarel, which are gonadotropin-releasing hormone agonists, that shrink fibroids and other hormones, may be prescribed to suppress estrogen. The drugs may cause menopausal symptoms and bone demineralization. Their use is limited to a 6-month period to reduce the fibroids and prepare for surgery. Uterine artery embolization involves the injection of special pellets into the selected blood vessels that supply the fibroid itself, resulting in shrinkage of the fibroid. It's performed under conscious sedation by an interventional radiologist. Some cramping, nausea, fever, MLEs may occur postoperatively as the fibroid degenerates. Postoperative pain may require an overnight hospitalization, and treatment with fentanyl or hydromorphone may be required. We need to maintain hydration and ambulation for these patients, and after 6 weeks, MRI confirms the effectiveness of the procedure. Myomectomy is the removal of the tumor from the uterine wall and can be accomplished by use of an endoscope via an abdominal incision or vaginally. It's performed in the proliferative phase of the menstrual cycle and does minimal damage to the uteral lining. Hysteroscopic endometrial ablation is a non-surgical technique that involves resection of submucosal fibroids followed by scraping and burning of the tissue. This procedure significantly reduces future fertility. Myolysis is laser or electrosurgical destruction of the fibroid. This can be done laparoscopically or vaginally and may preserve fertility. A hysterectomy is the removal of the uterus. This may be performed if the woman does not wish future pregnancies. A laparoscopic supracervical hysterectomy preserves the cervix and is less invasive, with fewer complications experienced. However, for benign disease, the robotic or vaginal route for hysterectomy is preferred. Many hysterectomies are performed unnecessarily because there are other common alternatives. Medical necessity for a hysterectomy includes cancer, an unmanageable infection or bleeding, or a serious birth complication such as a ruptured uterus. Nursing responsibilities include providing education to understand options, clarify misconceptions, and reduce anxiety for your patient. Endometriosis is a common disorder. This is where endometrial tissue is found outside of the uterus. It usually undergoes the same changes as the normal endometrium during the menstrual cycle, and it may bleed at the time of menses, which can cause irritation, pain, and the formation of adhesions. Other symptoms associated with this disorder include excessive menstrual flow, bleeding between periods, painful bowel movements, and painful coitus. Continuous hormonal contraceptive therapy, such as Depo-Provera, Ortho, Micronor, are indicated to treat this disorder. Menopausal symptoms, such as hot flashes, decreased libido, and reduced bone density may occur as well. If the woman does not desire children in the future, a complete hysterectomy and removal of all endometrial lesions is the treatment of choice. Treatment for menopausal symptoms may be needed postoperatively. Surgical management includes robotic surgery, reconstructive surgery, fistula repair, and hysterectomy. All right, now we'll discuss inflammation of the lower genital tract. Inflammations or infections of the vulva, vagina, or cervix most often occur when the acid environment of the vaginal secretions change. This enables the survival of pathogenic organisms. Organisms can also gain entrance into the vagina through contaminated hands, clothing, loss of skin integrity from trauma or surgery, and sexual intercourse. Vulvar infections typically occur as a result of skin trauma caused by itching and scratching. Although Candida albicans is normally present in low levels in the vaginal area, a change in vaginal pH can lead to an overgrowth resulting in vulvovaginitis. Signs and symptoms include lesions, dysuria, or painful urination, because the acidic urine comes into contact with the open lesions. Abnormal vaginal discharge can occur, pruritus, known as itching, and then women with cervicitis may experience bloody spotting after intercourse. Diagnosis of the specific condition is accomplished by culturing the vaginal discharge. Treatment includes specific treatment for the organism involved. It's also important to educate our patients over proper hand hygiene, avoidance of different hand creams. They can use local creams, vaginal suppositories, or systemic antimicrobials to treat this. They should also wear loose cotton underwear and use intermittent warm, local moist heat to provide comfort and decrease irritation. A non-judgmental attitude will empower the woman to ask questions and seek advice. Ensure that the woman fully understands directions for taking medications or applying the creams, and visual aids should be used whenever possible to ensure clarity of direction. Toxic shock syndrome, or TSS, is a rare and potentially fatal disorder caused by Staphylococcus aureus. It produces toxins that can cause shock, coagulation defects, and tissue damage if they enter the bloodstream. It is associated with the trapping of bacteria within the reproductive tract for a prolonged time. Risk factors include the prolonged use of high absorbency tampons, cervical caps, and diaphragms. Symptoms include sudden spiking fever, flu-like symptoms, hypotension, generalized rash resembling a sunburn, peeling of skin on the palms or the soles. Treatment includes hospitalization and intensive care with supportive treatments and intravenous antimicrobials. The nurse's role is to prevent TSS by education provided to women over hand hygiene when inserting tampons and the importance of changing tampons every 4 hours. Diaphragms and cervical caps should not be left in place for a prolonged time or used during menstruation. Cancer of the reproductive tract. First, there is vulvar cancer. Vulvar intraepithelial neoplasm, or VIN, refers to the growth of abnormal tissue on the vulva that may be precancerous. Cancer of the vulva is rare. It occurs most commonly with aging. Symptoms include red, brown, or white patches on the skin of the vulva. Treatment includes surgical removal of the pathologic tissue. Some strains are associated with HPV. Since the incorporation of the HPV vaccine, there's been a reduction in the incidence of vulvar cancer. Cancer of the cervix. Risk factors for cervical cancer include multiple sex partners, sexual intercourse with uncircumcised males, starting intercourse at a young age, younger than 20 years, multiple pregnancies, obesity, and a history of HPV or STIs. Regular pelvic examinations and pap smears may enable early diagnosis and provide the opportunity for early and more successful interventions. HPV screening can be done during a pap smear, and testing should occur every 5 years until the age of 65. Cancer of the uterus. The most common malignant tumor of the female reproductive tract is endometrial cancer. It's a slow-growing cancer that most commonly occurs after menopause. The treatment of choice is a hysterectomy with bilateral sapropharyngeal-oophorectomy. Treatment is often complicated by the fact that many women with cancer of the uterus may be elderly or have chronic conditions such as diabetes. Surgery is commonly followed by radiation and chemotherapy. Chemotherapy agents that are often used are adriamycin, planitol, 5-FU, periplatin, and Taxol. Ovarian cancer. Approximately 70% of ovarian tumors are benign. Ovarian cancer is known as a silent cancer because the signs and symptoms are often nonspecific and vague, such as fatigue or abdominal distension, with no detectable precancerous changes to the ovaries. An important risk factor for the development of ovarian cancer is having a sister or a mother with the disease or inherited BRCA1 or BRCA2 genes, which is also associated with breast cancer. Exposure to asbestos, talc powder, pelvic irritation, pelvic irradiation, or mumps has also been linked to the development of ovarian cancer. Women on hormone therapy should be informed concerning the risk for ovarian cancer. Factors that may prevent ovarian cancer include 1 or more term pregnancies, breastfeeding, tubal sterilization, and possibly the use of oral contraceptives. Disorders of the breast include fibroadenomas. These are commonly found in teenagers and young adults. They are firm, rubbery, mobile nodules of fibrous and glandular tissue that may or may not be tender upon palpation. Then there is fibrocystic breast changes. These are common during the reproductive years. These are palpable thickening of portions of the breast tissue associated with pain and tenderness. Multiple smooth, well delineated cysts may form that are most painful during the premenstrual phase of the menstrual cycle. The lumps make breast self-examinations more difficult and are commonly a source of anxiety. Then there is intraductal papillomas. These are the development of small elevations in the epithelium of the ducts of the breasts and under the areola. The ducts erode, causing a serosanguinous discharge from the nipple. Treatment includes excision of the mass and analysis of the discharge to determine whether cancer cells are present. Breast cancer. The development of breast cancer is believed to be related to the hormones estrogen and progesterone. Risk factors include familial history, early menarche and late menopause, late first pregnancy or no childbirth at all, previous breast biopsies, obesity, environmental exposure to hormone modulating chemicals such as pesticides and polycyclic aromatic hydrocarbons, such as those found in smoked meats, and consumption of alcohol. Signs and symptoms include nipple discharge or a change in the skin pattern, such as dimpled skin on the breast. It may also have like an orange peel appearance to it. Any unilateral breast change should be immediately reported to your healthcare provider. Even a short delay in diagnosis can result in invasion of surrounding tissue and metastasis to other parts of the body. Prevention includes a healthy lifestyle that includes exercise and diet that is rich in antioxidants and phytoestrogens such as vegetables, fruits, and whole grains. Soy products may protect against the development of many cancers as well. Diagnosis is done through breast biopsies and examining the tissue that is biopsied. Treatment options are based on the type of breast cancer, the stage of the disease, and the patient's age. A lumpectomy is the removal of the tumor only. A segmental mastectomy is removal of the tumor and a portion of the surrounding breast tissue and axillary lymph nodes. Total mastectomy is the removal of the entire breast and the axillary lymph nodes. A modified radical mastectomy is removal of breast axillary lymph nodes and the lining over the chest wall. And then a radical mastectomy is removal of breast, axillary lymph nodes, and chest wall muscles under the breast. Prevention, like I said, includes a healthy lifestyle. Next, we'll discuss reconstructive breast surgery. This is a form of plastic surgery. The first type is reduction mammoplasty. This is the reduction of breast size. A mammogram may be necessary for women older than 40 years of age. The amount and degree of scarring should be discussed with the patient, as well as the possibility of loss of sensation to the nipple or part of the areola. Augmentation mammoplasty. This is breast augmentation, usually initiated by patients who wish to improve their self-image and attain a sense of increased femininity. Reconstructive mammoplasty creates a new breast when the natural tissue has been removed during mastectomy. Preoperative care includes a good understanding of what is to be expected during and after surgery. We need to educate our patients over postoperative care. Postoperative care includes pain management, observation for signs of an infection, and continued supportive and educational measures. Because breast tissue is very vascular, bleeding may be a problem. Surgical dressing should be observed frequently during the first 48 hours after procedure. Body image and disfigurement issues, as well as the focus in our society on the breast as a marker of femininity or sexual attractiveness, make treatment for breast cancer a highly emotionally charged experience. Women require ongoing supportive care, and most will benefit greatly from participating in a support group and from visits by the American Cancer Society. A common complication of breast surgery is lymphedema. This is swelling of the arm that sometimes occurs after breast cancer surgery because of the damage to and resulting congestion of the lymphatic tract. The use of sentinel node biopsy with removal of additional lymph nodes only if the sentinel lymph node is positive for cancer has reduced the occurrence of lymphedema. Nursing interventions during the postoperative nursing care of a patient with a breast node biopsy or breast cancer surgery that can reduce the risk of development of lymphedema include to not assess blood pressure on the affected arm, to not give injections or do venipuncture on the affected arm, provide meticulous skin care, teach the patient to wear gloves in the kitchen and when gardening to prevent skin irritation or injury, teach the patient to avoid heavy lifting, advise the patient to wear a compression garment during strenuous activities, and advise the patient to elevate and exercise the arm daily. That concludes Chapter 38. Next class period, we will discuss Chapter 39, which is care of men with reproductive disorders. We will be online that day. I will have you guys log on at 12:30. There will be a beginning of class activity, followed by your lecture, and depending on the length of the lecture, there may be a post-lecture activity as well. I understand that this lecture itself is pretty lengthy in comparison to your other lectures. If you did not have time to complete your slides today, that is fine. Please complete them at your earliest convenience. There is no post-lecture activity for today. Thank you all and have a great afternoon.